my pleasure today to give a review of congenital anomalies of posterior fossa. Well, to know what's going on in posterior fossa malformation, we have to go back to know some embryological points. First, we all know three primordial tissues: endometrium, mesometrium, ectodermal. That's our body is formed of. Now we are going to concentrate on the ectoderm, which is formed the CNS, mesoderm, endoderm, ectoderm. Ectoderm will bend progressively to form neural crest, neural fold, and leading to neural tube. Well, anterior neural power deficiency lead to anencephaly, while posterior neural tube closure lead to spina bifida. Three physical stage start at week 4 for the brain: prosencephaly of forebrain, mesencephaly or midbrain, rhomboencephalon, hindbrain. At week 6, start to segmentation of telencephaly to 2 cerebral hemispheres, dienencephalon, and at the metencephalon start forming the bridge between the midbrain and hindbrain. Here we can see the lateral ventricle within telencephalon going to the third ventricle at the dienencephalon, passing through the aqueduct of Sylvius till fourth ventricle and then end in central canal. Actually, at the 3-week start of the primitive brain vesicle, at 6 weeks start segmentation. Almost at 11 weeks, all brain was formed. At birth, the brain totally covered. The embryogenesis of human brain is a complex process involving several stages and steps controlling multiple cellular and molecular signal pathway with a genetic component. The development of midbrain and hindbrain occurring during the process of ventral induction at 5th to 10th weeks of gestation. The primary cephalic vesicle, the prosencephalon, mesencephalon, and rhomboencephalon are formed. After the closure of neural tube, the cephalic cervical pontine flexure bend the axis of embryological central nervous system to the region of these vesicles. Middle vesicle, mesencephalon, and caudal vesicle, rhomboencephalon, differentiate structure of midbrain. The rhomboencephalon also differentiate into structures of the hindbrain. Well, again, we can see here the hindbrain formed tegmentum between cerebral aqueduct. At the pontine flexure develop further division of rhomboencephalon into upper and lower vesicles. The metencephalon and myelencephalon occur. This structure will further develop into the pons and medulla oblongata, respectively. Continuous indentation of the pontine flexure result in widening and thinning of the roof plate and separation of lateral wall of hindbrain, giving the rhomboencephalon characteristic rhomboid shape. This exposed floor plate represents the floor of the fourth ventricle. Steps during neural development. First, neuralization, neural tube closure, disjunction of neural cutaneous and neural ectoderm. Primitive brain vesicle and flexure diverticulation cleavage, neural differentiation, neural migration, formation of sulci and gyri, and lastly, myelination and maturation. A closure of neural tube starts between day 20 to 28. Early stage, the brain is hollow, but a tube without gyri, fissure, sulci. The tube bend thickened and develop surface feature. All normal structure appear at the predictable intervals. Brain smooth before 18 weeks. At 18 weeks, Sylvian calcarine cingulate gyrus apparent. At 22 weeks, Rolandic fissure apparent, followed by pre and post-Rolandic at 26 weeks. Between 28 to 37 weeks, secondary sulci apparent. At 40 weeks, full term, insula is entirely covered. While migration starts at 7 weeks, the embryonic cells migrate outward from the region of basal ganglia, germinal matrix, to the site of eventual cortex in successive waves, which are responsible for the normal cortical layers, 6 layers. This followed along process other cells, radial glia, which extend from the ventricle to the surface of the brain. The incidence of malformation is higher in children with intrauterine growth retardation and multiple pregnancies. Recent geographic factor may be important. Development of the brain continues for years after birth, and thus term congenital anomaly applies to some brain conditions that develop postnatally. Inflammatory response do not occur before the 6th fetal month or part, and part may be absorbed without trace of neurological or connective tissue repair. The same anomaly occurs as a result of genetic or environmental causes. Probably the most important factor in teratogenesis is the timing of insult, followed by the specific nature, agent, and genetic factor. Genetic factors like few cerebral anomalies are caused by simple Mendelian inheritance, but some examples including microcephaly, inherited autosomal recessive, 6 linked variety of hydrocephalus, hereditary congenital facial paralysis, autosomal dominant. Some anomalies have high risk of recurrence with families, and some anomalies also associated with important errors of metabolism. Most important group of trisomies like Down, other include translation or deletion like Cri-de-Chat syndrome and 6 chromosomes like Turner's or Klinefelter syndrome. Maternal age and maternal infection, for example, rubella and cytomegalovirus may play a great role. The development of the cerebellum starts at the 4th week of gestation, give rise to vermis and paravermal hemisphere. The cerebellar hemisphere developed in the 5th week and continue to differentiate until 2 years of life. Most of the cerebellar genetic abnormalities are believed to result from proliferation abnormalities that include cerebellar and pontine hypoplasia and dysplasia. Posterior fossa malformation are a special group of central nervous system anomalies that present during infancy with hypotonia, developmental delay, microcephaly, hydrocephalus. Recent discoveries that genetic and epigenetic factors that control hindbrain ontogenesis explain some of these disturbance cerebellar development. A comprehensive classification of posterior fossa malformation is proposed to the particular anterior attention to Dandy-Walker malformation, Joubert syndrome, and other cerebellar hypoplasia. A rare form of cerebellar hypertrophy is caused repeated obstruction at the foramen magnum is recognized. The importance of this cerebellum is language cognition and brain growth is stressed. We divide the most posterior fossa hindbrain malformation, including disease with cerebellar or vermian agenesis or hypoplasia, or cystic posterior fossa malformation, a cranial fault malformation, in addition to the view of embryologic development of posterior fossa and perspective of embryonic development. The classification of posterior fossa congenital anomalies has been a controversial topic. Advanced in genetic and imaging modalities have allowed better understanding of this embryological development of these anomalies. A new classification scheme correlates embryologic, morphologic, and genetic base of these anomalies in order to better distinguish and describe them. Although they provide a better understanding of clinical aspect and genetic of this disorder, it's crucial to radiologists to be able to diagnose the congenital posterior fossa anomalies based on their morphology, since the neuroimaging is usually the initial step when this disorder is suspected. The term agenesis, aplasia, hypoplasia, and atrophy are usually used and refer to the following definition. Agenesis, complete absence of the organ due to absence of primordial tissue. Aplasia, presence of primordial tissue with which never developed into final mature organ. Hypoplasia, histologically normal but incompletely developed. Atrophy, decreased size and weight of normally developed organ. Well, cerebellar agenesis is a very rare entity characterized by complete absence of cerebellum. Malformative disruptive cause should be considered when this entity is encountered. Recent genetic studies has described mutation of PTF1A gene, chromosome 10, which result in malformation phenotype of cerebellar agenesis. The gene is also linked to pancreatic development. Hence, the patient present with permanent neonatal diabetes mellitus. Disruptive causes are more common that include cases with normal development, is truncated by extrinsic factor, including infection and vascular malformation. Here we can see the cerebellar hypoplasia with severely maldeveloped bones. Vermian cerebellar hypoplasia refer to varying degree of incomplete development of the vermis and cerebellum. Genetic and metabolic causes have been described causative agent of cerebellar hypoplasia, including trisomies 9, 13, 18. A disorder of glycosylation, migration disorder, congenital muscular dystrophies, and isolated genetic syndrome. Interference with normal development of the cerebellum by teratogenic drugs, including cocaine and anticonvulsant drugs, or infections such as cytomegalovirus can result in cerebellar hypoplasia as well. It is important to differentiate cerebellar hypoplasia from cerebellar atrophy, since atrophy usually represents volume loss due to progressive injury and not real developmental anomaly. The differentiation is possible by identification of normal size fissure relative to the folia, or by follow-up studies demonstrating stability or cerebellar hypoplasia rather than the progression expected with atrophy. Here we can see severely maldeveloped cerebellum with small vermis. Well, to classify disorder of organogenesis, neural tube closure disorder, anencephaly, cephalocele, meningoencephalocele with Chiari type 3. Encephalocele is a protrusion of nervous tissue and meninges through a skull defect. The defect is caused by incomplete closure of the cranial fold. Encephalocele usually occurs midline and protrude anywhere at the line from the occiput to the nasal passage, but can present asymmetrically in frontal and parietal region. Well, how to differentiate encephalocele from cephalohematoma? Just do X-ray. Bone defect skull at the skull will be there in case of hematoma. Hydrocephalus often occurs with encephalocele. About 50% of affected infant has other congenital anomaly. So, golden rule, if you have one anomaly, you have to look for another. You can see a large encephalocele, posterior fossa. Well, this order of organogenesis in hindbrain consists mainly of Chiari malformation, Dandy-Walker spectrum, cerebellar vermin, hypoplasia, rhomboencephalosynapse. Arnold Chiari spectrum, complex brain deformity of the brain and cerebellum of 4 types. Type 1 ectopia of the cerebellar tonsil may be caused of late onset hydrocephalus and may be associated with minor deformity of the medulla. Type 2, by far the most common type seen in neonate and usually associated with lumbar myelomeningocele, consists of lengthening of vermis and tonsil of the cerebellum and their downward displacement through the foramen magnum into the spinal cord. Characteristic Z-shaped kink of the junction of the medulla and cord. Associated anomalies of the cranial fold are very common. Type 3 consists of cervical spina bifida, entire cerebellum being herniated through the foramen magnum, while type 4 is only cerebellar hypoplasia. Type 2 is the most common type, usually associated with communicating hydrocephalus. Cerebellar heterotopia are also common there. Protrusion of the cerebellar tonsil beyond the foramen magnum is common finding in Chiari 1, 2, and 3. Difference in the embryological base of the abnormalities explains the additional associated finding of each type. Chiari-1 malformation have been attributed to mesodermal defect, while type 2 and 3 derive from neuroectodermal derangement. Chiari-1 malformation may be congenital or acquired. The congenital form is development of dysgenesis of hindbrain, which inferior displacement of the cerebellar tonsil into the spinal cord through the foramen magnum is the most characteristic feature. Associated cervical syringomyelia has been documented in about 50% of the cases. Signs and symptoms of Chiari-1 malformation are related to compression of posterior fossa spinal cord, headache, often exacerbated by activities like increased intrathoracic pressure, coughing, laughing, and exercising, and lower cranial nerve, cerebellar, and brainstem dysfunction as well. The most distinctive clinical feature of Chiari-2 malformation is the presence of lumbar mariomeningeal seal and open spinal dystrophism in neonate. The presence of hydrocephalus manifested as enlarging head. Patients are usually younger than 2 years of age and may require emergency neurosurgical decompression. Chiari-3 malformation is the rarest type of Chiari malformation, characterized by an intracranial feature of Chiari-2 malformation, small posterior fossa, inferior displacement of content with associated occipital or cervical spinal dystrophism, through which is posterior fossa content herniate, resulting in encephalocele. An neuroectodermal defect similar to defect involved in Chiari-2 may explain this anomaly. Patients usually identified at an early age by the presence of cystic mass in cervical occipital region. Older patients will present with ataxia, hypotonia, and developmental delay. As with Chiari-2 malformation, massive thickening posterior fossa may lead to hydrocephalus symptoms related to increased intracranial tension. Theories of cause of Chiari malformation: spinal cord tether stuck down at lumbar myelomeningeal seal, thus not allowing normal descent during development. This leads to downward displacement of the brainstem and cerebellum. Other theory says hydrocephalus is the initial event, while pontine flexure failed to form is another concept. All these theories, a lot of argument against all these theories. As a malformation developed early in gestation at the age of 10 weeks. Well, here we can see, we draw a line from the tip of clivus to the trochlea periphery. And after we measure just this tonsil, 5 millimeter should be there. We should be certain that Arnold Chiari is there. Between 3 to 5 millimeter is doubtful. Well, don't depend on the coronal ever, because tilt of the head can lead to misfold. Dandy-Walker malformation, congenital posterior fossa cysts, posterior fossa malformation. Classic Dandy-Walker formation, Dandy-Walker variant, Cysterna Magna. Classic triad of Dandy-Walker: cystic dilatation of fourth ventricle, enlarged posterior fossa with upward displacement of trochlea periphery, Vermean dysgenesis. Mild form of Dandy-Walker: variable degree of Vermean cerebellar hypoplasia, minimally dilated or normal fourth ventricle, prominent retrocerebellar CSF space communicating freely with the fourth ventricle as keyhole appearance. Normal size posterior fossa. Dandy-Walker malformation resulting from failure of integration of the anterior membrane area in the plica choroidalis. Cerebrospinal fluid pulsation caused non-integrated anterior membrane area to expand posteriorly within the posterior fossa, forming a large posterior cyst represents the fourth ventricle. Since the membrane covers the posterior cyst, no communication with subarachnoid space exists. Cystic lesion including Dandy-Walker malformation, arachnoid cyst, and Blake's pouch cysts. Most of these entities have been populated to share a common origin in mesenchymal neuroepithelial signaling defect. Typical appearance of Dandy-Walker. deficient cerebellum and dysgenetic or agenetic verms. Another example with small and fourth ventricle and deformed axis of the midbrain. Mild form of Dandy Walker. CNS hydrocephalus, corpus callosum dysgenesis, neurological and neuronal migration abnormalities, and extracranial malformation of face like cleft lip and palate, malformation of limbs, digits, heart, urinary system. Cysterna magna, mild form of Dandy Walker. Some people are considered one of the variation of Dandy Walker. Enlarged Cysterna magna, communicating freely with pre-medullary subarachnoid space. Normal fourth ventricle there, vermian and cerebellar hemisphere are also normal. Although technically the Cysterna magna is not cyst, it has similar imaging appearance to cystic posterior fossa anomalies described above and play an important role in differential diagnosis. It's believed to occur due to pre-embolization of Blake's pouch, which allowed the pouch to enlarge and expand in posterior fossa before fenestration. This results in normal size fourth ventricle with free communication with Cysterna magna, with surrounding subarachnoid space. Generally, no hydrocephalus is there, and most patients are asymptomatic. Important imaging feature that differentiate condition from other similar entities, normal verms containing nine lobules, which differentiate from condition Dandy Walker proper, and vermian hypoplasia. Absence of hydrocephalus, which differentiate Cysterna magna from resisting Blake's pouch cyst. Lack of mass effects surrounding cerebellum and cerebellar falx, which differentiate anomaly from the arachnoid cysts. Neuroenteric cyst is usually midline, intraspinal, posterior fossa anterior. Density variable according to the content. Normal fourth ventricle is there usually. Associated segmentation anomalies and dysraphism can be there. Arachnoid cyst, midline posteriorly, less likely to be at CB angle region. CSF density and diffusion or restriction, fourth ventricle normal. On imaging, arachnoid cysts are large cystic structures that well-defined smooth margin. The cysts produce mass effect and displacement of the surrounding cerebellum without invasion and may be associated with hydrocephalus. Pulsation may cause scalloping of adjacent bone. Density measured by CT and the MRI equal to CSF fluid unless complication like hemorrhage and infection can present. Lack of communication of interventricular system is characteristic. The clinical manifestation of posterior fossa arachnoid cyst vary according to the age of the patient and size and amount of pressure that a cyst exerts upon the surrounding structure. Hemorrhage may cause arachnoid cyst to expand, intracranial increasing its pressure, leading to acute symptomatology in adult, fluid secretion from cyst, wall cyst. Ball valve mechanism and osmotic change may cause cyst to expand. In children, cyst expansion may cause mass effect on the hydrocephalus, resulting in enlarged head size and cerebellospinal compression manifestation. This eccentric cyst, typical for arachnoid cyst.
دكتور ياسر دقيقة واحدة كمان صراحة.
2 minutes. 2 minutes. Blake's pouch cyst representing embryological abnormality of posterior fossa membrane, failure, regression of Blake's pouch cyst. Gilbert syndrome, congenital vermin hypoplasia, rhomboencephalosynapsis, congenital fusion of cerebellar hemisphere, Lerman-Duclos syndrome, dysplastic gangliocytoma of cerebellum, and Chiari-form malformation, median cerebellar hypoplasia. In Gilbert syndrome, molar tooth brain stem, bat wing, or open umbrella fourth ventricle. This is the typical appearance of the Gilbert syndrome, molar tooth appearance with closed umbrella fourth ventricle. Rhomboencephalosynapse, hypoplastic single cerebellum, fused cerebellar hemisphere, absence of severely hypoplastic vermis, narrow diamond keyhole shaped fourth ventricle, absent primary fissure, transverse volume. abnormal head movement, ataxia, and developmental delay. We can see here one chamber cerebellar hemisphere with thickened foliae. Lermont-de-Cloux syndrome, last one. Diagnostic clue, striated cerebellum, thickened ribbon-like folia, bizarre gyroform appearance, T1 hypo and T2 hyperintense mass lesion with hypointense striation. Generally, one hemisphere may extend to the vermis, mass effect there. Clinically, increased CSF, cerebellar ataxia, brain stem, nerve pulses finding. Can see here, Lermont-de-Cloux syndrome, coronal flare, left cerebellar hemisphere is a rare appearance of pattern, slight enlargement of left cerebellar hemisphere. Can see this hamartoma, no enhancement there. Well, this last one, in sum, to sum this, hindbrain malformation disease with cerebellar vermin agenesis, aplasia or hypoplasia, cerebellar agenesis, rhomboencephalosynapsis, vermin cerebellar hypoplasia, Lermont-de-Cloux syndrome, Walker-Berg syndrome. Thank you.
Thank you, Professor Yasser, for this